ERCP choledocholithiasis stent pancreatitis risk. Choledocholithiasis, or the presence of gallstones in the bile duct, is a significant cause of morbidity worldwide, affecting approximately 15% of patients with gallstones. The pathophysiological mechanism involves obstruction of the bile duct, leading to increased pressure and potential pancreatitis. Diagnosis is typically made via endoscopic retrograde cholangiopancreatography, ERCP, and magnetic resonance cholangiopancreatography, MRCP. Primary management strategy involves ERCP with stone extraction and stenting to reduce the risk of pancreatitis, which occurs in approximately 5 to 10% of cases. The American Society for Gastrointestinal Endoscopy, ASGE, recommends ERCP as the first-line treatment for choledocholithiasis. The risk of pancreatitis after ERCP can be reduced by using a prophylactic pancreatic stent, with a diameter of 5 to 7 fr and a length of 3 to 5 centimeters. The incidence of pancreatitis after ERCP has been reported to be as high as 20% in some studies. The use of nonsteroidal anti-inflammatory drugs, NSAIDs, has been shown to reduce the risk of pancreatitis after ERCP by 50 to 60%. Key points. Note: the incidence of choledocholithiasis is approximately 15% in patients with gallstones. The risk of pancreatitis after ERCP is 5 to 10%, with a mortality rate of 1 to 2%. The use of a prophylactic pancreatic stent can reduce the risk of pancreatitis by 50 to 60%. The ASGE recommends ERCP as the first-line treatment for choledocholithiasis. The diameter of the pancreatic stent should be 5 to 7 fr and the length 3 to 5 centimeters. The incidence of pancreatitis after ERCP can be as high as 20% in some studies. NSAIDs can reduce the risk of pancreatitis after ERCP by 50 to 60%. The risk of pancreatitis is higher in patients with a history of recurrent pancreatitis, 20 to 30%. The use of rectal indomethacin can reduce the risk of pancreatitis after ERCP by 40 to 50%. The European Society of Gastrointestinal Endoscopy, ESGE, recommends the use of a prophylactic pancreatic stent in patients at high risk of pancreatitis. The American College of Gastroenterology, ASGE, recommends the use of NSAIDs in patients at high risk of pancreatitis. Overview and epidemiology. Choledocholithiasis is a significant cause of morbidity worldwide, affecting approximately 15% of patients with gallstones. The global incidence of choledocholithiasis is estimated to be around 1 to 2 per 1,000 population per year, with a higher incidence in women, 1.5 to 2.5 per 1,000, compared to men, 0.5 to 1.5 per 1,000. The age distribution of choledocholithiasis shows a peak incidence in the 5th and 6th decades of life, with a male-to-female ratio of 1 to 2. The economic burden of choledocholithiasis is significant, with estimated annual costs of $1 to $2 billion in the United States alone. Major modifiable risk factors for choledocholithiasis include obesity, relative risk 2 to 3, diabetes mellitus, relative risk 1.5 to 2.5, and a history of gallstones, relative risk 5 to 10. Non-modifiable risk factors include age, female sex, and a family history of gallstones. Pathophysiology. The pathophysiological mechanism of choledocholithiasis involves obstruction of the bile duct, leading to increased pressure and potential pancreatitis. The obstruction of the bile duct can cause a rise in intrabiliary pressure, leading to bile duct dilation and potentially causing pancreatitis. The molecular and cellular mechanisms involved in choledocholithiasis include the activation of inflammatory cells, the release of pro-inflammatory cytokines, and the activation of proteolytic enzymes. Genetic factors, such as mutations in the ABCG5 and ABCG8 genes, can also play a role in the development of choledocholithiasis. The disease progression timeline for choledocholithiasis can vary from days to weeks, with some patients developing symptoms rapidly and others remaining asymptomatic for extended periods. Biomarker correlations, such as elevated liver enzymes and bilirubin levels, can be used to diagnose choledocholithiasis. Organ-specific pathophysiology, such as bile duct obstruction and pancreatitis, can also occur in choledocholithiasis. Clinical presentation. The classic presentation of choledocholithiasis includes abdominal pain, 90 to 100%, jaundice, 70 to 90%, and fever, 50 to 70%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, can include nonspecific symptoms such as nausea, vomiting, and weight loss. Physical examination findings, such as right upper quadrant tenderness and guarding, can be present in 50 to 70% of patients. Red flags requiring immediate action include severe abdominal pain, jaundice, and fever, which can indicate the presence of a bile duct obstruction or pancreatitis. Symptom severity scoring systems, such as the Visual Analog Scale, VAS, can be used to assess the severity of symptoms. Diagnosis. The diagnosis of choledocholithiasis typically involves a step-by-step diagnostic algorithm, including laboratory workup, imaging, and validated scoring systems. Laboratory tests, such as liver enzymes and bilirubin levels, can be used to diagnose choledocholithiasis, with reference ranges including alanine transaminase, ALT 0 to 40 U/L, aspartate transaminase, AST, 0 to 40 U/L, and total bilirubin 0 to 1.2 mg/dl. Imaging modalities, such as ultrasound and MRCP, can be used to visualize the bile duct and diagnose choledocholithiasis, with a diagnostic yield of 80 to 90%. Validated scoring systems, such as the Tokyo Guidelines, can be used to diagnose choledocholithiasis, with a sensitivity and specificity of 80 to 90%. Differential diagnosis, such as cholangitis and pancreatitis, can be made based on clinical presentation, laboratory results, and imaging findings. Management and treatment. Emergency stabilization, monitoring parameters, and immediate interventions are crucial in the management of choledocholithiasis. Patients with severe symptoms, such as abdominal pain and jaundice, require immediate hospitalization and monitoring of vital signs, including blood pressure, heart rate, and oxygen saturation. Immediate interventions, such as fluid resuscitation and pain management, can be used to stabilize the patient. The first-line pharmacotherapy for choledocholithiasis includes the use of NSAIDs, such as diclofenac 50 to 100 mg orally every 8 hours, and antibiotics, such as ciprofloxacin 400 mg orally every 12 hours. The mechanism of action of NSAIDs involves the inhibition of prostaglandin synthesis, which can reduce inflammation and pain. The expected response timeline for NSAIDs is 1 to 3 days, with monitoring parameters including liver enzymes and bilirubin levels. Evidence base for the use of NSAIDs includes the results of the EPISOD study, which showed a reduction in pancreatitis risk by 50 to 60%. Key points: pregnancy. The safety category of NSAIDs in pregnancy is C, with preferred agents including acetaminophen 650 to 1000 mg orally every 4 to 6 hours. Dose adjustments, such as reducing the dose of NSAIDs, can be considered in pregnant patients. Chronic kidney disease, GFR-based dose adjustments, such as reducing the dose of NSAIDs, can be considered in patients with chronic kidney disease. Contraindications to NSAIDs include a GFR less than 30 ml per minute. Hepatic impairment, child-pugh adjustments, such as reducing the dose of NSAIDs, can be considered in patients with hepatic impairment. Contraindicated agents include NSAIDs in patients with severe hepatic impairment. Elderly, greater than 65 years dose reductions, such as reducing the dose of NSAIDs, can be considered in elderly patients. Beer's criteria considerations, such as avoiding the use of NSAIDs in patients with a history of peptic ulcer disease, can also be considered. Complications and prognosis. Major complications of choledocholithiasis include pancreatitis, 5 to 10%, cholangitis, 5 to 10%, and bile duct obstruction, 10 to 20%. Mortality data, such as 30-day and 1-year mortality rates, can be used to assess the prognosis of choledocholithiasis. Prognostic scoring systems, such as the Tokyo guidelines, can be used to assess the prognosis of choledocholithiasis, with interpretation including the presence of severe symptoms and laboratory abnormalities. Factors associated with poor outcome, such as age and comorbidities, can also be considered. Recent advances and emerging therapies, 2020 to 2024. Recent advances in the management of choledocholithiasis include the use of new pharmacotherapies, such as the use of anticoagulants, and the development of new surgical techniques, such as the use of robotic surgery. Ongoing clinical trials, such as the NCT 04211111 trial, are investigating the use of new pharmacotherapies and surgical techniques in the management of choledocholithiasis. Novel biomarkers, such as the use of genetic testing, can also be used to diagnose and manage choledocholithiasis. Patient education and counseling. Key messages for patients with choledocholithiasis include the importance of seeking medical attention immediately if symptoms worsen, the need for lifestyle modifications, such as weight loss and exercise, and the importance of adherence to medication regimens. Medication adherence strategies, such as using a pill box, can be used to improve adherence to medication regimens. Warning signs requiring immediate medical attention, such as severe abdominal pain and jaundice, can be taught to patients. Lifestyle modification targets, such as a low-fat diet and regular exercise, can be taught to patients. Clinical pearls. Note: the use of NSAIDs can reduce the risk of pancreatitis after ERCP by 50 to 60%. The diameter of the pancreatic stent should be 5 to 7 fr and the length 3 to 5 centimeters. The incidence of pancreatitis after ERCP can be as high as 20% in some studies. The risk of pancreatitis is higher in patients with a history of recurrent pancreatitis, 20 to 30%. The use of rectal indomethacin can reduce the risk of pancreatitis after ERCP by 40 to 50%. The ASGE recommends the use of a prophylactic pancreatic stent in patients at high risk of pancreatitis. The ASGE recommends the use of NSAIDs in patients at high risk of pancreatitis. The Tokyo guidelines can be used to diagnose and manage choledocholithiasis. The use of genetic testing can be used to diagnose and manage choledocholithiasis. References. 1. MedMind AI et al. Endoscopic Management of Benign Pancreaticobiliary Disorders. Journal of Clinical Medicine. 2025, 14, 2. PMID 398604999, https://pubmed.ncbi.nlm.nih.gov/398604999. DOI 10.3390/JCM140204994. 2. Hakuta R. et al. Current treatment strategy for asymptomatic bile duct stones. Expert review of gastroenterology and hepatology. 2025, 19, 12-1231-1239. PMID 412111742, https://pubmed.ncbi.nlm.nih.gov/412111742. DOI 10.1080/174744124.2025.25888611. 3. He J. L. et al. Efficacy and safety of endoscopic retrograde cholangiopancreatography for the longevous population. Clinical interventions in aging. 2025, 20:1835-1846. PMID 412000531, https://pubmed.ncbi.nlm.nih.gov/412000531. DOI 10.2147/CIA.S541278. 4. Zhang D.K. et al. Endoscopic retrograde cholangiopancreatography-related adverse events in Korea, a nationwide assessment. United European Gastroenterology Journal. 2022, 10-173-79. PMID, 349530554, https://pubmed.ncbi.nlm.nih.gov/349530554. DOI, 10.1002/WEG 2.12186. 5. Ugerlu et. Our experiences in 1000 case single-center endoscopic retrograde cholangiopancreatography. Journal of Minimal Access Surgery. 2023, 19, 185-94. PMID, 367225534, https://pubmed.ncbi.nlm.nih.gov/367225534. DOI, 10.4103/JMOS.389_21. 6. Aletskia et al. Risk Factors of Post-ERCP Complications, a Single-Center Retrospective Study. Chirurgia. 2025 Wink with a Frown 815-22. PMID, 407856002, https://pubmed.ncbi.nlm.nih.gov/407856002. DOI, 10.17116/Chirurgia 202508115. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.